This is meant to be a more practical approach to nuts and bolts, what you do, with a little bit of why, because I can't just tell you do this, do this, do that, right? Okay. So, these are the objectives. What's the role? What's the process? What's the exempt? I actually didn't go into exempt, expedited, and convening review very much, but just a little so you have some sort of idea. When I was talking to Adam the other day, I think his eyes crossed right in front of me with like, what are you talking about? And then we're going to look at some agreements and who owns the data and that kind of thing, because that's really important. And then the most important thing, I think, for you guys, especially those who are just starting, like haven't put in their first protocols, how do you really navigate the EIRB? There is so much information in there. It is a really powerful tool, and unfortunately, people just don't know. So what I did last year, what I did was like put it on live, but this time it was just too inefficient. So I've got a bunch of screenshots of what EIRB looks like and where to find it. Okay, I told you I'm going to give you a bunch of numbers, but here we start. The only thing I want to say about this, but part of our job at the IRB is to keep you guys out of trouble. We're on the same team, and it's just really important to remember that. It's not the IRB versus the researchers. We're not out to make you guys, petty this and petty that. When you do this a lot, you do want language that makes sense. You do want language that's readable. You do want sentences that flow. I mean, the English language is important when you're doing a consent form and you are, communicating information to people of all sorts of educational backgrounds. So I don't want to belabor these, but these are just, everything we do comes because of federal regulations. It's important to remember that. These are mandates, these are regulations, you're held to them, and we help you hold to them so that, i.e., back to my first slide, keep you out of trouble. So all research with human subjects has to be reviewed by an IRB. It has to be reviewed yearly. That may change with the change in the common rule. They're going to change the common rule, but how they're going to change it, when they're going to change it, are they going to change it like they said? I don't know. Nobody knows, so I didn't go into the changes of the common rule today. But they're going to change it. Maybe for minimal risk study, we don't have to do yearly review. But for right now, this is what it is. So any revisions to any documents uploaded in the IRB have to be changed in the IRB by an amendment. You have to follow IRB protocol. Whatever's in your protocol, whatever's in your study space, that's what you have to do. Doesn't matter, that's just it. And you can't deviate from that. If you deviate from that, you have to submit a protocol deviation. But it's really important to know that you have to keep that. And then, any study documents, and I'll belabor this later, have to be, anything you give to a subject or a potential subject, a patient, has to have a review, has to be in the EIRB, has to have IRB approval. You can't give them anything, a summary or anything. So when we look at the ethics of doing research, part of the question we ask is this ethically, is the risk scientifically justifiable? So when we talk about research summaries, that's part of our job. Is the science there to, even for a blood draw for a kid, or for any intervention? If the science isn't there, then it's a no-go. And that's why the background is sometimes it feels like we're doing this for no reason. When you do your study summary, what I'm looking at when I look at the background is there a reason to do this study? So it is important. If there's no reason to do it, there's no reason to put subjects, and for most of us it's children at risk. So what is research? It's a systematic investigation designed to develop or contribute to generalizable knowledge. One case report is not generalizable knowledge, right? And we at the Duke IRB feel like 2 case reports and 3 case reports are still not generalizable. Once you get above 3, it starts to become generalizable. So when you're thinking about research, it's like it's systemic and there is knowledge to be gained from that. And then the other thing that seems so trite, but it's not had to look at this and think about it for a while, is what is a human subject? And we all know if it's a person and they're in front of you, well, that's a human subject. But for research, it's data through intervention or interaction with the individual or their PHI, their private identifiable information. So if you're going to look in their charts, that's PHI, that's a human subject. Now, so that's pretty, I think most people like, that's seems pretty reasonable. But the thing is, if you look at the last bullet point here, data or samples derived from humans, regardless of whether or not subject identifiers are associated with materials, and regardless of whether or not the data or samples were originally collected for clinical purposes, that's research, that's a human subject, you're doing human subject research, even if you're getting, old discarded blood or whatever. So that's also important to keep in mind. QI is not research. The key difference between QI and research is research studies are intended to create new knowledge that can be generalizable. QI uses existing knowledge. There are checklists up on the IRB. If you're wondering, is my project QI or is it not, there's a checklist up there that you can go through and that'll help you figure that out. Now most people go ahead and submit their QI to the IRB because if you want to publish it, then you can say, yeah, we submitted to the IRB and they said blah, blah, blah. But you don't have to submit QI projects to the IRB.
Yeah, we usually do recommend that they do it just
Yeah.
in case there's any chance.
Yeah. Exempt research. Now, I'll talk a little bit more about this later, but there's no exempt research for prisoners and children. The regulatory burdens on doing research in children are greater because they are deemed a vulnerable population. Prisoners are also a population. So there are some exempt research that you don't have to, get IRB approval, but you can't decide that. You have to submit it to the IRB and they will tell you it's exempt and it shows up and it's in your queue and it's part of your research. So when you think about, as I told you, case reports and IRB, retrospective case series, that starts becoming different, right? More than 3 needs IRB protocol, submission, etc. And the IRB will allow you to do retrospective studies for whatever reason, whether it's case series or case control or whatever. You're allowed to do retrospective, but here's my word of warning. The retrospective is as of date of IRB submission. So let's say you want to do, A versus B, whatever, you're going to go back and look and you think, I got some time this month, I'm going to set my IRB, I'm going to go ahead and submit the IRB, but you don't really plan to do it for another 6 months. Well, I would say leave it in pre-submission, or don't even put it in pre-submission, because the minute you submit to the IRB, the minute they know that you are planning to do research, retrospective review, you can't do anything from today's date moving forward. So if you put it in today, and there's a case tomorrow that you want to include in your retrospective review, you can't do it. So it's data submission for a retrospective thing that the IRB will hold you to. So if you're planning on just, getting the protocol and you're thinking of doing it, but you're not going to do it for 6 months, I would wait until you're close to your time, because if not, you're going to miss time and data.
And you can't amend the dates, huh?
You cannot amend the dates. Occasionally, very, very, very occasionally, I've seen it once, where there's a special circumstances, but no, we don't allow you to, that's pretty like firm, set in stone almost, so you can't say, oh, well, I decided, talk to Jody Power about that, she'll tell you. Now, device studies may need an IDE. The thing I wanted to point out, now I'll talk more to you about IDs and INDs, but algorithms are devices. In vitro studies can be devices. So things you don't think of as devices may actually be a device. And I'll show you how you deal with that. And drug studies, if it's being used for FDA indications, you upload the packet insert. If it's outside of FDA indications, you have to have an IND or an exemption or an abbreviated IND. And I'll go into that a little bit too. I don't want to burden you too much with specifics. But so what is needed for an IRB? Protocol or research summary? One or the other. Think about a waiver. We're going to go into this. The informed consent form. Now, in kids, once they turn 18, magically, boom, they're no longer minors, right? They're adults. So if you have anyone who's 17 and whatever in your study, and they are going to turn 18 while on study, then you have to reconsent them with an adult consent. I know it's burdensome, but that's just regulatory. Now, even though, and I don't have this anywhere in the slides, so I'll say it now, even though at 18 they're considered adults, to hold research data, how it says you have to hold it for at least 6 years or until a child turns 21. If you think about it, it doesn't make sense. Why is it 18 on one thing and 21 on the other? I don't know, it just is. So you have to hold all of your data until the youngest child turns 21 for research studies. Let's see. There are checklists. There are IND checklists right on the IRB website. There's IDE checklists for investigational device. There's exemption or abbreviated IDEs, and like I said, I'm going to go into that, but I just wanted to have a place. So, typical documents, protocol, research summary, consent forms, waivers, HIPAA issues, investigative brochure, package inserts or device, FDA correspondence, if you're getting an IND from the FDA or IDE from the FDA, all that has to be uploaded. And I don't think well, some fellows may do this. Any ads, any surveys, any questionnaires. If the IRB has not reviewed, don't give it to a subject, because that's how you get yourself in trouble. And a lot of these, like, you have, this basic questionnaire, that, what's your height, weight, what's your whatever. I mean, those get done in days, not weeks, not months. It's, minimal risk, expedited reviews. A chair will look at that and say, oh, sure, It usually is days. Okay, so this is the IRB website. How many here have ever been on the IRB website? A minority, or half, about half. So the other half. So this is, the home page, and this tells you there's so much information here. So if you look here, there's, I think I just have screenshots. So for example, about us, staff and chairs. It tells you all the staff, but more importantly, it tells you who your specialist is. So what I put here for IRB staff, they find your board specialist. This was a drop-down menu. I put pediatrics, I get Jessica Ordax. So you have a question, that's your contact person. All pediatric protocols, once they hit the IRB, get funneled through Jessica. So she's a good person to know, she's a really nice person, and you call her, and if she can't find the answer, she will find the answer for you. So we really, welcome young investigators to call us and say, hey, I don't know what I'm doing, or, whatever questions. But that's how you figure out who your contact is. The other thing about this, a little unique about Duke, is we have 8 boards, 8 sitting boards. That's about 2 a week. It is 2 a week. We also have a board 10 that's made up of chairs that if, like for Christmas break or whatever, if we have a big burden and we want to push them through, we'll convene an extra board. And you can see they're twice, they're a full board, you have a chair, a vice chair, you have everything that's needed. The bottom line is, at Duke, we do pretty well getting protocols through fast. And we've looked at our metrics. I think they're one of the best. And you can look and see, if you're like, you have a protocol and there's a problem with it, you can see if it's going to full board, you can see who's the chair, you can email the chair and any issues, as I said. Now, forms are really important. That's, from the home page, there's the forms, and once you hit forms, you get this. And this gives you templates to do anything in eIRB. Advertisement and flyer templates. Most advertisements, if they're going to have a Duke medicine, they have to go through creative services, and we'll take care of that on the back end and tell you it has to go here or whatever. Continuing review forms, consent form templates, just outside Duke key personnel form, you got to, instructions on the research summary, or review preparatory to research, telephone scripts. If you're going to be calling patients, subjects, sorry. If you're going to be calling subjects, we want to know every word you're going to say. Isn't that awful? We're in your business here. Waivers, everything is here. And this is me going to consent to forms and like pulling, here's the pull down menu. You click on what you need and you get what you want. So waivers, people don't understand why I need a waiver. So once you have informed consent and a subject has signed the document that says, yeah, you can look at my personal information, you can look at my medical records, you can look at that, you've got consent. Right? But if you're trying to figure out who are the patients who have X diagnosis and with maybe Y criteria, where you don't want to be asking every patient who comes in, are you interested in this study, if they don't have X and Y, right? You wanna be efficient. So therefore, you wanna pre-screen either your clinic log, or you wanna do something, you wanna look at their PHI without having the authority to do it, basically. So you need a waiver for ascertainment unless you're recruiting your own patient population. That's the one caveat. It has to be only your patient population. So most studies do have waivers. If you're doing a retrospective chart review, you've got no business in people's charts. You've got no business doing this, right? Unless the IRB says, okay, we approve you doing that, that's where the waiver comes through. Now, things that you don't think about, so there's a lot of repositories these days. There's blood, there's stool, there's cheek swabs, there's data. There's just data that are in repositories. And all sorts of places around Duke are setting up repositories. So if you want to go in and pull some data from that repository, you're going to need a waiver. Because even though they got consent to put it in the repository, they didn't really specifically give you consent to pull. What people tell subjects when they're agreeing to be in a repository is that any study that is going to be used with your data, your samples, your whatever, will go through the Duke IRB. We will make sure that this is ethical, et cetera, et cetera, et cetera. So you do need a waiver even if you're pulling from a repository. And the other thing you need a waiver for is if you're reviewing charts of deceased patients. And there is a specific form for that. And here it is. When you look at waivers, you get decedent research, that's, and basically that says that if they're 90 and above, you're not going to say their age because they're too easy to identify. With more and more people in their 90s, that may turn to 800 at one time. But basically that you're not going to disclose. Or if you're going to disclose, you're going to tell the relatives you're going to disclose. I tell you, 99.9% of people just say, we're not going to disclose who it is. Here's waiver of documentation. This people get confused all the time. The majority of the waivers that you fill out is going to be waiver or alteration of consent or HIP authorization. So it's the bottom one of the three, because it's not just informed consent, it's HIPAA authorization, and we all know HIPAA stuff. Now, when you open up a waiver, this is what your choices are. Are you scheduling research activities before you get your like, for example, you have a protocol where somebody's going to come in and get an MRI. And so you have a screen, a telephone screen, that you contact people and say, because this is not a cold call, we don't allow cold call. Let's say they're in your division. Let's say it's nephrology. It's like they know Adam, right? So Adam says, I'm doing this study, and I've got this phone script, and I want to do this MRI on your kidneys. You don't have to consent for that now, but I want to go ahead and schedule you just in case you agree. So you can do that through my extra care. So that's scheduling research activities. The other waiver part is ascertainment or recruitment, which I told you. And then the other waiver, when you open it, is conduct of the research without obtaining verbal or written consent or authorization. So that, for example, is when you do your database study and you're pulling from that repository. That would be conduct without conduct the research. So these are your choices. And then, that was above. And then you have to answer all these questions. The one I wanted to bring to your attention is the first one. List the elements of informed consent and or HIPAA authorization for which waiver or alteration is requested. Provide the rationale for each. What do we really want for you? We're requesting waiver of all elements of informed consent and HIPAA authorization. If that's the only thing you get from my talk, that'll save you at least one mod. That's the language they want. Request the waiver of all elements of informed consent, HIPAA authorization. And then the waiver form is going to go through what PHI do you want. They're going to ask more specifics. And so you have to say why you want it and all that. Now, on our IRB, EIRB, we have standard language. And I don't think people necessarily know that it's all here. And so, so it's going to be standard language for Duke DNA, standard language for contraception. It's all here. You just got to look for it. So for example, allergic reaction, anesthesia, biopsy, liver, skin, blood draw risk, standard language, you guys don't have to come up with this. Bone marrow, certificate of confidentiality, clinicaltrials.gov language, communicable diseases, right? If you're gonna test, for example, for Hep B and they're positive, you have to report it to the state. You have to disclose that in the consent form, it's all there. If you compensate a research subject over $600 in 1 year, then you have to report it to the IRS. That language is here. Contraception is so important, females, males. The cost for expensive treatment, CT scans, the risk for that, DNA definition, DNA genetic banking, drug and food interaction, ECG risk, endoscopy, if you're going to use gadolinium, HIV testing, if you're going to send x-rays, it's hard to really de-identify them. Injury language, if you're going to use a LAR, a legally authorized representative, these are for children, in our case, or adults who are cognitively impaired. So, for example, a lot of the ICU studies or neuro ICU studies, you know, there are subjects initially are cognitive impaired, and then they get better. So what happens when you have that sort of situation where you're dealing with the cognitive impaired, the legally authorized representatives, which for us, it's mainly, you know, for kids, it's mainly their parents, thank you. But for adults, it's like the spouse. There's a very legal way to go through who the LAR is, but if somebody retains, if you expect that people are going to get better, then they need to be reconsented once they're better. And this tells you all that. Mouse antibodies, you know, what's the risk of a mouse antibody, MRI. I'm just bringing these up because I just don't think people look at, though they're here, the risk of peripheral neuropathy. What is peripheral neuropathy? Radiation risk. There's something you go online and calculate the radiation risk. Disclosure language, risk management, Duke Regional, we shouldn't have to worry about that definition. RNA, sample retention. The statement of consent is on the consent form template. Sedation. If you're going to use student employees in research, you have to say, you know, your grade's not going to be affected, your job's not going to be affected by tumor biopsies. I think that's all the standard language. So the research summary, as I said, there should be enough of the background of why the research study. The other thing we want to know, why are you doing it? What are you doing? There's so many people who turned in a research summary that doesn't say what you're doing. They say, oh, just look at table blah, blah, blah of the protocol. It's like that, it's not going to fly for a second. You know, I don't want to have to look at table blah, blah, blah of a protocol. I want you to tell me what you're doing. And without spending 10 pages, you know, you can upload one of those charts, for example, for drug studies that they always send. What are the risks? What's the payment? What's the cost? How are adverse reactions in the essay going to be monitored and reported? Now, if it's a small, you know, if it's a small study, you're just doing it here, you say, I'm going to report it to the IRB if I get any A's or SA's, not that I expect. The other thing is, if this is an investigator-initiated study and you're the fellow and it's really your study, work on your research summary. Make sure that's perfect. Your research summary serves as your protocol. You don't have to upload both, as long as it's reasonable. The reason why we, you know, for drug company protocols, those are, you know, 300 pages. Yours are probably not. So, you know, there used to be a page limit of 3 pages for research summary. That's gone away. If you keep it 5 or 6 pages, you know, you won't get any flack. If it's 20 to 30, people are going to say, get a research summary. But for a lot of the fellow-initiated studies, you know, you don't want both. Why? Because if you make an amendment down the line, you would have to amend 2 things. While if you just have the research summary, if you have 1 thing to amend, it makes it easier and streamline the process. So the regulations say consent forms must be written in language and reading level understandable to your study population. That's probably one of the biggest problems with consent forms. I had, you know, a consent form I looked at in the last week that said, well, in, you know, controlled studies, blah, 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 and I took out all the blah, 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 and I said, we don't know. So that they were trying to say, we don't know. So it's like, we don't know, which, you know, instead of going through all this medical, like, legalese language, you just, you know, take it down to your simplest level. And then the other thing is, you know, that's really important for any consent. You do the consent, you sign the consent, you have the consent witness, You make a copy of the consent, you give a copy to the participant. You always give a copy of the consent form to the participant. The other copy, the original you keep, and then you send a copy to the medical records. And then you document somewhere that you have consented, that you've given them. I have a dot phrase, and I usually document it within the clinic note. If it's not a clinic note, you've got to have somewhere to document. You can do a note to file, you can do a phone note. Somewhere it's got to be documented in the medical record that your patient signed consent, is now a research subject, and you gave them a copy of this consent.
Can you give them that copy electronically? Like, let's say they don't want the piece of paper, they'll
No.
just email it to
No,
you.
because it has to have everyone's signatures on it. It has to have their signatures and their date and time.
So if you consent somebody over the phone, do you need to fax them the consent form?
So
to
you
sign
can
and then
fax,
it
you
back?
can email. If it's a minimal risk study, you can even do a verbal consent. So there's all sorts of creative ways you can do things. And the IRB has a lot of experience with this, and again, I would reach out. But you don't necessarily, I mean, you could have a waiver of alteration of consent saying you're not gonna get signed consent, this is a minimal risk study, and so you're just gonna get verbal consent. That's perfectly okay. The other way people do it is to fax it, to email that, to mail them. You're gonna be mailed a hard copy, we're gonna discuss it now, I'm gonna go through my script. Once you signed it, you mail it back to me. So there's all sorts of ways to do it. You don't have to do it in person, you're absolutely right. Now, for a high-risk study, you don't have to do it in person. But we're talking for a low-risk study. Electronic copy. Corey, I guess if you scanned it, I think if you scanned it, as long as they have the signature and they've agreed to it, that you've provided them with a copy, I wouldn't mess around with it. I just print it off and give it to them, so then they can use it.
And more like a mother-infant care, do you have to document in both charts that the mom signed the consent?
Oh, gosh, no. Because probably, in that case, you're probably only consenting the mother.
Well, I have an IRB where I'm consenting for the mother for one visit and then the baby for longitudinal visits.
So there are two consent forms?
Yes.
Then you need to, if you have a consent form for just the baby, then you need to document somewhere that the parent has, that they're enrolled in this study. Sometimes we allow for mom, like if you're just gonna get birth weight and APGAR scores or something like, your contact with the baby is just the neonatal period, like at birth, you can just have the mother sign the consent. You don't have to have a separate minor consent, which is what I thought you were talking about. But if you have two consents, you should have them. So, on the IRB website, I don't know if it's coming or if I've showed it to you, but the consent form templates, make sure you use minor for minors and adults for adults. I've already talked about that if minors are gonna turn 18, you gotta reconsent them and use an adult consent, use standard templates, use lay language. And the other thing that is not anywhere written anywhere is that let's say you have a consent form and it's been reviewed by the IRB chair or somebody, and they've sent you back track change documents, got some comments like, what do you mean here, clarify here, this is better language, that kind of thing. And so you are then gonna clarify, modify, whatever. You have to do that in a track copies form and send us back the track changes copy. Because I wanna see because if not, we get really irritable with a track change, because it makes the work so much harder. Most of the time I won't even look at a non-track change, and it's not just consent form, it's waivers, it's summaries, it's protocols, it's anything. Anything we ask you to change, you change and you send it back with a track changes, you know what I'm talking about, right? Everybody knows what I'm talking about. And we want to see what changes you have, and the easiest way to do that is always use track changes version of any document that you're sending back to the IRB. So this is, pretty much what you need. Purpose of the study, funding source, study activities, duration of participation, your risks, your benefits, costs, compensation. It's always going to say, research is voluntary. That's usually at the beginning and at the end. You have any right to withdraw. What alternatives? Often people don't fill in alternatives. If it's a study where there are no alternatives, well then you don't have to put alternatives. But if there's alternatives, they need to go in there. treatment for study-related injury, and the Duke lawyers will make sure you've got that right, because no one's gonna do that. Who will see the data, how it will be managed, when it will be de-identified or destroyed, and whom to contact with questions, concerns, or study-related injuries. Obviously, any IRB, and this is all in the ICF template, the IRB, any questions to the IRB, come to the IRB. Any questions about the study goes to the PI. And it has to be the PI. So in terms of how to consent, you have to provide a competent study team member to conduct the consent. Who is competent? The PI gets to decide. You know, one of the things about being a PI, you get all the privileges and all the bad things that come with it. When you're a PI of any study, you're responsible for the actions of anybody on the study team. So if you have a colleague who doesn't do consent right, or you know somebody messes up, whose fault is it? It's the PI. The FDA holds us to this. OHRP holds us to it, and it's a little scary. I try not to think about it too much because I don't think I'd sleep at night, because I have too many studies going, drug studies, and it's like anybody messes up, and I've had some challenges with research coordinators, and they can destroy your life. But you as a PI are responsible for anything anybody does. So in order to get consent, you have to have a competent study team member, which the PI has decided. You have to let them ask questions. You have to have a private location. It can be over the phone or internet, and an appropriate length of time. And we absolutely do not allow cold calls at Duke. So you know what a cold call is? You screen somebody and say, I want to find all lupus patients who presented before age 12. Let's just pick a nice disease. And so you do your deduce and you find all 12, and you're not a member of the clinical team, and you decide, I'm going to call them all and see if they're interested in this. You're absolutely not allowed. What are you allowed to do? You're allowed to come to rheumatology and say, hey, I got this great study. It's not really anything to do with you, but I want to study this in lupus patients. Will you send the letter? So then you draft a letter. I put my name on the letter. I sign the letter. You sign the letter. It's not a cold call anymore, because somebody known to the patient is approaching them. See the difference? Absolutely no cold calls.
Sorry, we can't be PIs. The fellows are not allowed to be PIs.
The fellows are not allowed. But I'm assuming that some of you guys are going to be PIs, and I want you to understand the responsibility of being a PI, because it's big. And so when one of your faculty mentors is being a PI for your study, you know, that's a lot of trust on their part. I don't think about it that way, but it is a lot of trust. So here's from the IRB website, DUHL sample consent. Now you have clean and tracked. Just ignore the track. The tracked is for what new changes do we have to our consent form templates since you last looked. And it's really for those experienced research coordinators who know this back and forth, and they just want to know what's new. But for the regular people, including me, the only things I ever pull up to start a consent form is 4 adults clean and 4 minors clean. Because it'll go through what you need to do, for example, reporting if it's FDA, if it's non-FDA, if it's off the shelf, if it's outside sponsor, if it's Duke sponsor, that all matters about what language you put in there. But the consent form templates have it all. There's also a sample consent in Spanish. I didn't really address Spanish, but if you're gonna, yeah.
Sorry,
No,
let me finish that thought, because it was
Yeah.
back to the cold calls, I guess.
Yeah.
So what about for inpatients, approaching inpatients?
You have to have a member of the clinical team approach. So this happens all the time around Duke. So let's say in neuro ICU, they're studying a new way to monitor intracranial pressure. And so it's a team, but they're not taking care of the patients. So the study team has to come in. All they really have to say, the clinical team has to come in. All they really have to say is there's a research project. Would you be willing to hear about it?
Sure.
Now, if you can give them a couple lines, that's even better. But that's really all they have to do, is somebody known to the patient has to approach them to say, will you be willing to hear about research? And they have every right to say no. I always try to, give them some idea, because our nurses will do it in clinic. We're all running around, clinic, we're all busy, and we've got a registry going. It's a minimal risk study, and so the nurse will go into a patient's room and say, would you be willing to hear about research today? That's all she says. And if they say yes, our research coordinator comes in and talks to them about a registry. It just can't be anybody they don't know, you know? Spanish, I didn't go into this at all, but for Spanish or other language consent, there's a short form and a long form. You can get your consent form translated into Spanish. They're taking away, it used to be really, really expensive because you have to have a certified Spanish interpreter or somebody doing it, and then you'd have to back translate into English. Luckily, they're taking away that requirement to back translate, right? Because most people don't read Spanish, so if you have a forward translation from English to Spanish, you gotta just take the interpreter's word, but, you know, taking it back from Spanish to English to make sure it's still the same was the thought, and it's really burdensome, so that's going away. So that's one way to do it. The other way to do it is something called the short form. So there's, on the IRB website, your best friend, there's a form, and it says, basically it says, a translator has read the study to me and I agree to participate, basically, in a lot more words. So you can have a translator come in and read the consent form word to word to a Spanish or another language speaking person. They just sign the short form and then you give them the English consent form. You know, it's just too expensive, I think, and too burdensome. Sometimes we don't want to cut out Spanish speaking patients from research. Now, this is new. This is, you know, we just take our marching orders from the FDA and the OHRP. So now, on every consent form that has been submitted as of November 1st of 2017, you have to have a concise summary. And that means exactly what it means, concise. This is about as big. There is a little button you can push when you're looking at consent form templates that says, take me to concise summaries, and they show you several examples. But this is perfect. The purpose of the study is to compare the GI tract in children with inflammatory bowel disease. Now, I wouldn't let gastrointestinal tract go through. To me, that's not lay language, but I'm a little bit picky about lay language. And with inflammatory bowel disease in healthy children, the information may help us. How will it help us? So what they want to know is why you're doing the study, what they're going to do in broad terms. So participants in the study will have a blood sample collected and a small piece of tissue removed from their intestine during their clinically scheduled procedure. And then they're going to look in the laboratory, and the parents of participating children will be asked to complete a questionnaire. Your child's participation is complete once the medical record and questionnaire have been reviewed and the tissue and blood sample have been collected. What are the risks? Risks of bleeding, risks of blood sample. I probably would have put risk of confidentiality, but that's going to be in the consent. If you are interested in learning more about the study, please continue to read below. I think this is actually a really good change for consent forms. It tells you in a nutshell what you really want them to know. So think about your risk when you're making these consent forms, when you're doing your concise summary. Think about really what you're asking your subjects to do and why. And it's very simple, very short. It's meant to be short because it's at the top of the consent form and everything else follows. So we're not going to talk about exemption. I don't think that we're just going to talk about IDE, so individual device exemption. So as I said, a device can be an in vitro assay. If you're going to develop risk, let's say you're looking at, you're taking some blood and you're going to put it, and you're looking for markers, whether markers of disease, markers of progression, whatever, markers in the lab. And so you can think about it as a device. The marker is a device. It's a bit weird to get your mind around, but that's how we're looking at it. So anytime you have a device, so here it's defined. Instrument, a lot of this is really, like, you know, you're going to put a valve in somebody's heart, that's a device. Well, that's everyone can understand. So instrument, apparatus, implement, machine, implant, in vitro reagent, or other similar or related article. Now, a lot of times, we have to do device determinations when it hits full board, and a lot of times we'll say, oh, this is early investigation. It's not really a device. You're just, you know, looking for markers. It's not quite a device, and we'll help you do that. But it's things that you don't think are devices are devices, and so this is the most common way to get IDE exemption. So we say the device is a diagnostic device, and the sponsor, and you can be the sponsor, your PI can be the sponsor, you're a faculty member, with applicable requirements. So it has to be, in order to get an exemption from the IRB, it has to be non-invasive. It does not require invasive sampling procedure that presents significant risk. Now, blood draws, even in kids, are not considered invasive. They're not invasive. And I've seen, for example, sometimes they're doing tumor biopsies, and as long as it's not deep in the liver or deep in the lungs, as long as it's accessible, minimal risk will allow tissue biopsies as non-invasive. Does not introduce energy into the subject. So we've looked at this with the FDA. Energy includes light. If you shine a light on a subject, that's energy. It's not, I kid you not, it's not up for exemption, and will not be used as a diagnostic procedure without confirmation of the diagnosis by another medically established diagnostic product or procedure. We don't want anyone making decisions based on this research test that's going to impact clinical care. You guys heard the word potty? No? So about, how many years ago? 9, 10 years ago now? Something like that. There was a researcher at Duke, a breast cancer researcher, who was falsifying data. And he was falsifying markers, and subjects were being assigned to treatment based on this falsified data. That's the last thing in the world we ever want to see, right? I mean, his career, I mean, I'm surprised he didn't get his nothing. He did. He's no longer at Duke. You know, sometimes when people misbehave, we all pay the price. And that's what's happened with federal regulations with research. When I started back in the 80s, I mean, we had an IRB, it met once a month. I mean, there was just not this regulatory burden. And what's happened is more people have done research and things get more sophisticated and you get cheaters. And then everyone puts up ways to find the cheaters, right? And so we're all paying the price for people who misbehave. Remember that when it was like, why is there all this regulatory burden? That's why. So what happens if you do have a low risk device that you want to use, but it introduces light, so we can't do an IDE exemption? Well, then we can grant you, because we have all the powers, because we're the IRB, we can grant you an abbreviated IDE that you don't have to go to the FDA for. If it's a true, like you're going to put a valve in somebody's heart, that's got to go through the FDA. If it's a minimal risk, but you're introducing some energy, there's some reason why it doesn't meet the criteria we talked about, we can grant you an abbreviated IDE, and this is pretty easy because you look, it's not a banned device, it's labeled. It's you're going to get IRB approval. You're going to follow all the things, all the regulations for a research project. Monitoring. You're going to keep records. You're going to make sure the investigators comply and the sponsor complies. Yes. You've got abbreviated IDE, and you're done. So as long as it's not, as long as it's a low risk, then we can issue you abbreviated IDE and keep you away from the FDA, which is what you want. Now, IND is for an investigational new drug. Most new drugs, you're not going to be involved in writing the protocols, right? They come from a drug company, they come from a sponsor. Now, and I have seen some fellows do some projects, for example, with Benadryl. You can take Benadryl, and you're going to use it for something that it's not labeled for. So you know that we all use drugs off-label, especially in pediatrics. So the only thing that matters from a regulatory standpoint, is it indicated, is it labeled? If it's not indicated and it's not labeled, well then you need an IND. For non-sponsored studies, we can give you an exemption, or you can get an individual IND from the FDA. There is a group of people here at Duke who will help you with the IND process. It's a mess because it's the government. You got to register on clinicaltrials.gov, which is a horrible, horrible, evil website. It's really hard to figure out how to enter your data afterwards. It's just, I don't know if anyone's done it, but it's horrible. It's evil.
It's worse than horrible.
Yeah, it's just evil, right? It's just incredible. I could have never done it. So for an IND, what do you have to? So this is for an IND exemption. So again, in your checklist, the investigation is not intended to be reported to the FDA as a well-controlled study in support of an indication for a new use. You want to use Benadryl to put kids to sleep at night. It's not FDA indicated, right? You use Benadryl. This is just a bad example, but it's an example I can think of. You use Benadryl for allergies, but it's not indicated to put kids to sleep, but you want to study it. So you're not gonna ask the FDA for a new label, so that's fine. It's not, so no change in labeling, that's A and B. It's lawfully marketed, and it's not intended to support a significant change in the advertising. So the label, the advertising, and it does not involve, this is tricky, because PEDS is the acceptability of risk is always less than PEDS. And I didn't go through, I think Chuck, Mike Conton went through pediatric risk levels. Did he go through that with you guys? Does anybody remember? There are too many numbers. He did, okay, that I thought he did. Okay, so it does not involve a change in the route, the dosage level, the patient population from the approved label that significantly increases their risk or decreases the acceptability of the risk associated with the use of the drug or product. This is where we get in trouble with PEDS, because we cannot allow, because we studied in kids, that decreases the acceptability of the risk, so you gotta be really careful. And we have to think about, is this something that we can really do through an IND exemption, or do you really have to go to the FDA? And the other thing is just, you're gonna follow all the laws, basically. So exempt research, I'm not gonna go into this a lot, but there is research that happens in commonly accepted educational settings, or surveys, or methodologies that are public, which we're probably all never gonna do. And for example, taste and food quality evaluation. Is A better than B? You can set up in a grocery store. You don't need a conformed consent. You don't need anything like that. So there are exemptions. The other thing in the common rule, and this may change, but right now, if you're going to look at existing data, documents, records, specimens, and if these sources are publicly available, you will still need to go through the IRB if the information, it will not be eligible for exemption if the information is reported by the investigator in such a manner that subjects are identified. I said it just the opposite. But in order to get exemption, it has to be, you cannot write down anyone's name, date of birth, medical record number, no PHI can be written down. It's much easier to get a waiver than to do research without writing down who you need. Because you can't just be, and then expedited review versus convened board. Expedited review is what I do in my desk. So you've submitted a minimal risk study, or a continuing review, or a amendment that we think is minimal risk, does not increase the risk of an existing study. The chair will do the expedited review. Like I said, it takes days, not weeks, not months. Minimal risk. Now we run into this all the time, right? So you could say for a cancer patient, they go through LPs all the time. So LP is minimal risk because it's not anything different what they normally encounter in everyday life. It doesn't work like that from a regulatory standpoint. So minimal risk, the probability, magnitude, harm, or discomfort anticipating the research are not greater in of themselves than ordinarily encountered in daily life. Daily life, normal daily life, not sick daily life. So when you're looking at risk, you can't look at risk for CF or lupus or, and look at the diagnosis. This is for a normal, healthy child. And expedited review happens outside of the convened board. If it's a convened board review, you have a lot of people sitting around a table. There has to be a PEDS expert at the board. If it's a PEDS study, there has to be a member from the community. There has to be, there has to be certain representation, but including a non-medical person or a community member and somebody who's an expert in pediatrics. So research studies that cannot be expedited. So new greater than minimal
Egla,
risk.
can I just
Yeah.
ask something?
Yeah, please.
Are these closed sessions? Could these guys go and observe one?
You could go, you'd have to have permission, but absolutely you could observe. In fact, I think it'd be a great idea.
Yeah.
I would suggest you don't stay the whole 4 hours.
Right.
I suggest you plan on an hour or two, because we usually do the new studies first. And that's where that's where the most of the discussion happens. So you can spend a couple hours there. I think
Especially if you're gonna do clinical research.
Exactly. So,
I presume you're not allowed to sit down on your own study?
you are not allowed to sit on your own study. You are asked, if you're at the board, you're asked to leave the room.
Okay.
And that gets documented. You know, I have had sponsors, so drug companies say, oh, we need proof, we want the roster for the day of who was at the board meeting when your study was presented to make sure you weren't there. IRB will not release the roster. They will send them a letter saying, this person was not there for this review, but we're not gonna give drug companies your name, right? Anyone's name sitting around the board. That's just, that's just not right. But no one is allowed to hear them. Even if you're a distant collaborator, you're not allowed to sit in that room. X-rays, a lot of this makes sense. MRIs with contrast. MRIs without contrast, they can be expedited. Blood draws in a non-healthy adult population over 50 mLs in an 8-week period or greater than 2 draws per week. For children, it's the lesser of either 50 mLs in an 8-week period, 3 mLs per kilo, or greater than 2 draws per week. Really, if you're submitting an amendment, hopefully it doesn't matter too much whether it comes to you in days or weeks. If it comes to full board, it's probably going to be weeks. Now, some IRBs don't have eight boards a month, and you have to, IRB review takes forever. We're pretty fast here. Prisoners, I already talked to you about potential damaging information, and I've had this come through as expedited, where somebody wanted to ask kids about their sexuality. It's like, no, that goes to full board. I'm not approving that, right? HIV, hepatitis, alcoholism, mental illness, that's not expeditable. That is something that needs to go to full board with a lot of people thinking about this. So I think I already talked to you about this, so I'm not going to go into this. But the PI, again, bottom line, you're going to have a research career, even if it's going to be a little clinical research. You're ultimately responsible for all aspects of the research program. Try not to think about it too much, like I said. I wouldn't sleep at night. So data. So I had a very wonderful fellow do a very nice study, a qualitative study of medical adherence in adolescents with lupus. And you think, well, that's great. We need to learn more about that, right? And so she finished her fellowship, or he finished her fellowship, and boxed up all the tapes from the interviews and took it to their next job. Put it in the apartment, and there it sat till I realized that we were missing consent forms and missing data. The data that you generate here at Duke does not belong to you. And that's something that I don't think well understood. It doesn't belong to you. You did not sign any institutional agreements with Vanderbilt for your collaboration. You didn't sign it. I didn't sign it. The dean signs it, right? Somebody in the administration signs it. The data does not belong to you. You can take a data set that has people, and let's say you're going to move. You need a materials transfer agreement to bring that data with you. Do not take data unless you have permission to take data. That's a good way to, it belongs to the institution. And you need agreements in place to transfer specimens or just data from one place to the other. This is how people can get in trouble. A lot of this is just people don't know, right? You don't know. You think, it's my data. I did the interviews. I transcribed them. I have them. So what it cost me was we shipped them all back. I had an hour face-to-face time with the privacy officer at Duke, where I was educated in privacy, thinking, oh, I did not need to spend that hour there, but I'm the PI, because fellows can be PIs, and therefore I paid the price. Your data does not belong to you. Doesn't mean you can't take your data, but you need your institutional, you need a materials transfer agreement is what you need. So it's the university official, not the researcher, that signs the MTA. And it all gets decided. There's collaborative research all the time happening between Duke and other institutions, and it's a pretty easy thing to do. It doesn't take too long, but you've got to have it. So it's what you're going to transfer, who's going to see it, is there going to be PHI? Doesn't matter if there's PHI or not to transfer data. You're going to transfer the data, you need an MTA. In fact, most MTAs do not have PHI attached to them. The rights to invention, there's a lot of the lawyers get involved, but you've got to have something in order to get data. Now, there's a new NIH rule. It's not that new. It's probably I mean, we heard about it about a year ago. Now, if you're gonna do a multi-center trial, the NIH is tired of dealing with IRB delays. So if you're doing a multi-center trial and you're the PI at Duke, Duke IRB is gonna be the IRB of record, and other centers are gonna cede their review to us. We cede review to there's these like Western IRB, there's these IRBs that are there to make money, and they're there to serve people. It's not associated with an academic center. We will cede review to these people. However, it always has to have local review. So we look at all the documents that have been approved, and we have to also have them approved here. So the NIH got tired. NIH multi-center trial, they want one IRB, but all the other IRBs ceding to us. Doesn't mean they don't get to look at the consent form. It doesn't mean that they don't change things. For example, there's state laws that affect research. In North Carolina, if you are a 16-year-old and have a baby, who signs for your baby? No.
Really?
No, it's the grandparents. It's
That's
the
different.
Remember, North Carolina progressive, right? Yes, it is different. That's gonna be different in every state. But the 6-year-old's a minor, and unless they're emancipated and it takes a court order to become emancipated, then it's the grandparents that have to sign. So that's not gonna be the same from state to state to state, and that's where local IRB review comes through. Again, to keep you guys out of trouble, right? You will need an institutional and IA in place. The local IRB will still review, and protocol still needs the usual. You still need to go to the CRU. You still need it, you still need to go through all the layers that are put in there. Why? Because it's cheap. So, IRB authorization agreements are the IAAs, and that's between medical centers. The IIAs are individual investigator agreements. That's for like people who are not associated with the medical center. Like you have a practice out in rural Roxborough that you want to recruit from, then you use your IIAs. But those are easy to get, and then almost on time. When in doubt, contact me, because we're here to help. I'm happy to answer any other questions. That was great that you guys asked questions, because I can't think of everything to put on here. Any questions? Thank you for your attention.
Thank you, that's helpful.